What up, y'all? It's Wednesday, Premed Q&A. Today's gonna be a little different. Give me a second. I gotta get the rest of my stuff set up, but I just want to get on here on time. Give you guys a second. Hop on here. You don't want to miss this. Get here. Get here. Who here likes Sade? I'm a big fan of Sade. I used to only listen to Sade almost exclusively back when there were CDs and such, and we didn't have all this fancy streaming technology, Spotify. Brianna, what is up? What is up? I'm good today. I'm going to try to pronounce this name. I apologize for butchering this. Arkaprabha. Hello, welcome. Keybert, what is up? Caitlin, what's up? CR June, hey. Galaxy Motion says, when is the event at Cal State Long Beach? It's supposed to be mid-September, but I'm kind of behind in some stuff, so we might push it to October. We'll see how it goes, but keep a lookout for that announcement. See if it can be late September, early October, somewhere in there. Utham, what is up, man? What is up? McDonald's ketchup. Okay, that's good. Samantha, you finally made it. No work, no school tonight. I'm loving it. And then Michael Campbell finally caught a live stream. Yes. And Pat found the cheese. Yeah. Good book, right? Our book club book this month. Pat is referencing right there. I'm excited for that. We're going to break that down. Nina's already. I talked to Nina. Nina and I video conference last night for like an hour and a half. And we talked about her pre-med stuff, but we also talked a little bit about preparing for that session. So Nina's going to be bringing us a dynamic summary of that book and what we can learn from it. Jonathan, what's up? Kasim, what is up? Hector, what is up? Alexia, first time watching live. Yes. And you like Sade? Is that what the I do is about? I hope you like Sade. So am I doing a UCSD event? I don't know if I'm doing a UCSD event. So this is what's interesting, guys. Like I mentioned on my Facebook stream earlier this week that I break the status quo. I like doing my own thing. I don't like limitations. And so it's interesting. I'm a resident at UCSD, so you would think UCSD would be really down with having events and stuff, but there's always so many restrictions. And I'm not with restrictions. I like to bring the real, bring the raw, and actually help people. So it's kind of an uphill battle with UCSD. So I don't have the patience to deal with that. So I like my Cal State Long Beach. I like my UCLA peeps, so they hooked me up, and so that's where we'll be at. So Karina, getting to watch one live. Yes. Issa, what is up? Ula Wasan. I like that. All right. Brianna, your book's on the way. I'm liking it. Amazon actually, so it's been so long since I read the book. I had to reorder it from Amazon. And Amazon lost my copy. And then it turns out that it wasn't actually supplied by Amazon. It was just shipped by Amazon. It was a big wreck. But anyway. So Joshua said, what is the book? Who Moved My Cheese? Yes, it is Who Moved My Cheese. Good guess right there. Alexia, what is up? All right. Hello, everybody. Let's get started, right? Everybody's ready to get started. So tonight, let me see if I get these markers going here. Let me make sure my kid has not dried out my markers, which he, right? I just said that right up top, and he dried out that blue one, so we're done there. Red is working. Black is working. Let me get one more color. Let's see if green is working, or if he dried that one out too. Clearly my kid likes the colored markers. All right, we're going to switch it up. Let's see. Oh, when the green works. All right. So, who's ready to have a good time tonight? Tonight we're doing respiratory physiology. Respiratory physiology. I'm going to bring you guys the real deal. I'm in the ICU this month, working in the ICU. We have a bunch of sick patients. And for the anesthesia people, we have a special anesthesia ICU, which is all heart failure, lung failure, heart transplants, lung transplants, people with artificial devices, all that kind of good stuff. For their situation. That's why they're in the ICU. So tonight I thought it'd be fun, right, to do two things. One, I'm going to teach you some respiratory physiology that you may or may not be able to use, but physiology is important, so it's always good to have some physiology in your pocket. But more importantly, I'm going to teach you about kind of creating frameworks for things. And one of my more popular videos on here that some of you may or may not have seen is my mental frameworks video. And sometimes it's abstract when I talk to people and I tell people about framing how they think about things and simplifying things down. But I think walking you guys through how I view respiratory physiology I think can help you kind of frame your topics and things that may seem complex and make them very simple and understand. So, Roberto, you are late. It's unacceptable. Leave right now. No, I'm just joking. So if you guys are ready to get some good respiratory physiology up in you and get some good learning and how you think about things, give me a like right now. Carmen, what is up? Give me a like right now. So Carmen is balling out right now, interviewing for medical school. She's going to be going to a top medical school. I'm so proud and so happy for her because she's a wonderful person who worked hard, put her time in, and it's going to pay off for her this cycle. So I'm excited for her. We're going to get it going. Who's ready? Who's ready? Give me a like right now. Let me drink some of this water so I can get a little parched. All right. All right. So this is what I wrote down. And so I just took 2 seconds to kind of think about how I was going to frame it for you guys. And I think that's always the hardest part. Anybody's ever taught anything is you have a framework in your mind and you have all this way you think about things, and that may not always translate out to what other people are, thinking about it. So let's bring what I think about it. I'm going to try to relate it to what you guys think. So lung physiology. The reason I thought about this today was because I had a patient who had very sick lungs. In fact, she actually had a lung transplant. So she's a patient who had COPD, chronic obstructive pulmonary disease, and we'll explain that disease in a second, but I think first it's important to talk about the lungs. And as part of her COPD, her lungs were so bad they could not function anymore on their own, and so she required a lung transplant. She still has one bad lung, but we replaced one of her lungs with a new lung. Fancy lung, brand new lung. But she's not doing so well in the ICU right now, and one of the issues is compliance. And her lung physiology has been thrown off and perturbed, and so we're trying to think about strategies and ways to optimize her lung function, taking into consideration her lung compliance. And so you may not be familiar with lung compliance, but you're familiar with compliance in general, and I think that's a good way. No, we'll start. We'll take a step back, and we'll walk through lungs, how you should walk them through. And as you walk through any of your physiology, you can use this as a framework for any of your physiology classes. Actually, any class in general. But this is the way that I frame everything in physio, and I think that is universally applicable. So with anything you ever study, the very, very first key to getting a good understanding of something in an effective manner is to ask yourself, what's the function? And within function, you want the functional machinery, which in the terms of the body comes in anatomy. And so for the lungs, what's the function of the lungs? Why do we care about the lungs? Why do we need lungs? What do they do for us? What is their function? What is their role? And let me stop for a second also. So I have been doing Facebook streams, and you guys are such jerks. You did not tell me that when I write on the board on Facebook that it's reversed, and you actually are having to read the writing backwards. So I'm going to be writing a lot on the board tonight. So if this is reversed, I need to know, because then I need to press another button to unreverse it. So can you see this frontwards? Okay, it's frontwards. Thank you. You guys are such jerks. You let me just write and think I'm doing great stuff. And little do I know, my wife, who the only one who cares about me, is like, hey, you're writing backwards on the board. So now I know. I've got to hit a button. You guys don't care about me. I thought you guys cared. You guys don't care. So function, and in terms of physiology, that's anatomy. So understanding the basic function of the lungs, we said is what? Someone said it. I think gas exchange. So when we talk about gas exchange as a function, so gas exchange, what gases are we talking about that we exchange? Samantha's getting fancy. She said pH balance, oxygenate the blood, remove CO2. Very important. We want to bring in oxygen in, CO2 out. Okay? Oxygen in, CO2 out. Why do we want oxygen? Because oxygen is used in the electron transport chain, which allows us to do energy, to create energy, which allows us to do work. When you don't have energy, you can't work. It's the same thing with our body. Oxygen is the number one, right? The last acceptor in the electron transport chain that really gives you the juice. And if you don't have oxygen, you have to do anaerobic metabolism, which sucks. You get much less energy, and therefore you can do less work. And what do we require to do work in our bodies, guys? What has to do work? Everything, every single cell, every single tissue, every single organ, everything in your body, enzymes, everything needs energy to work. And so without oxygen, you can't get energy, you can't do work. Major problem. So I call oxygen fuel. Fuel in, like a car. CO2 out. Well, what is CO2? It also comes from the electron transport chain. Right? Where does CO2 come from in the electron transport chain? Do we make it because we like it? TCA cycle. Very good, Kevin. Do we like CO2? Why do we make CO2 as part of the TCA cycle? Krebs cycle. Jackie, another name, yes? Is it on purpose? Do we use the CO2? It's a waste product, exactly, right? What's the product we actually want? We want that acetyl-CoA, right? And then we kick off CO2 because if you go to organic chemistry, right? Everything in organic chemistry is a bunch of C's, right? Carbons bound together. So what CO2 is a cleavage reaction to get rid of this COO group and create CO2 and allow us to have another reactive species over here to do work, which is acetyl-CoA. Yep. So we create this CO2 on accident so we can access this. But it's made in the electron transport chain as a waste product. And like waste in your house, right? When your room gets junky, you can do no work. Anyone who's has a car, you get your oil changed because you want to remove the dirty, mucked up, terrible oil that's stuck in there so that way your car can do more effective work. It's the same thing with your exhaust pipe. We're getting rid of carbon monoxide, another, carbon with a single O, chopping it off and cleaving, creating that catalytic reaction, in your catalytic converter in your car and spitting out the carbon monoxide. So it's a waste product. So, our lungs are responsible for gas exchange and bringing oxygen, the fuel of our bodies, in and getting rid of CO2 waste out. And it's very important that you guys understand this, and a lot of students lump these two concepts together, and even doctors lump these two concepts together. And one thing I think that's very cool about being an anesthesiologist is that you know stuff. You know your stuff. I'm an expert in physiology. I'm an expert in a lot of different, aspects of healthcare. It's wonderful because then you can bask in your excellence and your expertise because then you meet other people who are not anesthesiologists and who don't know their physiology and you can just laugh at their stupidity. And this actually happened a while back. I was in the ICU, another ICU, and there was a surgical resident and the patient was having an issue with oxygenation, and they didn't understand the difference between oxygenation, which is O2 in, and ventilation, which is CO2 out, and they were adjusting parameters that wouldn't address the oxygenation problem. But anyway, so we've written that down. So now we have a basic understanding of what we're trying to do. Both of these are transported in the blood, so the oxygen is a mechanism, or the lungs are a conduit for moving gas from the outside into your lungs, into your chest cavity to exchange in the blood and to get in the blood system and then to pull CO2 out of the blood into the lungs and go up. So how do the lungs carry out that function? Let's look at the structure. This is a human mouth there, don't worry about it. That's your upper airway coming down. And of course, you guys know I double as an artist. So this is my artist skills coming at you. Boom. Okay. Yeah, art skills on point. You darn right my art skills are. Recognize. Okay? So the functional anatomy of the lungs. What is the mouth to the top of the trachea called in your anatomy class or in your physiology class? Mouth to the top of the trachea. Anuj wants his name shouted out. You are shouted out, Anuj. And Kyle S. says, finally catches a live stream, and I'm doing stuff that requires the board. Don't worry, Kyle. There's also a moral to this story in a lecture that you don't need to see after this. So the esophagus. No, the esophagus is where you eat, guys. The esophagus is not where you breathe. So Frank is close, says pharynx. Aisha's close, says the larynx. Frank got even closer, the oropharynx. And that makes sense, right? Because our mouth is the oral cavity, and the throat area here is the pharynx. So therefore we have the oropharynx. Yay! What is the oropharynx's job in our respiratory physiology? What is the oropharynx's job in respiratory physiology? Cowboys do suck. I agree with MTIS. Opening to atmosphere. Filter. Well, Adrian, you're close. Filter in what way? What does that mean? Mucous membrane. Almost, Aisha. The mucous membrane, right? The oropharynx, right, does what? Does what? No, it doesn't transfer gas, doesn't do any of that stuff. What is your mouth? Full of mucus, it is wet. So the mouth, the oropharynx, and your nose, the nasopharynx, their jobs, right, they're wet, is to humidify and moisturize the air as it comes in. So you moisturize that air, that way the air doesn't go down into your lungs and, right, dry your body out, right? It comes by that conductive, and you can have heat loss, fluid loss. It's bad stuff. So it humidifies the air. Humidification. Which is why for anesthesia, we put a tube in, right, to breathe for patients. We bypass the oropharynx and go right to the lungs. So now we're delivering air from the outside directly into the lungs, putting the patient at risk for massive amounts of fluid and temperature loss. So to prevent that, we put a special device called a humidifier onto the ET tube, the endotracheal tube, to keep their lungs as moist as possible. So anyway, oropharynx. What's below the oropharynx? The cords, yes, that's the cutoff of the oropharynx. What's below the cords? Calvin made it live. What is up? Someone just asked, do I use a glide scope or do I do direct laryngoscopy? I do both. So it depends on the situation. So no, larynx is wrong, Samantha. Larynx is part of the oropharyngeal laryngeal area above the cords. Below the cords is right. Frank is right. The trachea. We are into the trachea with the tracheal rings, right? That's how you know as an anesthesiologist if you're in the trachea or if you're in the esophagus. We can use a device called a bougie, and it has this little stick with an up point on it, and we can actually slide it into wherever we are. And if we feel like bump, 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 we know that we're in the trachea. If it feels smooth, we know we're in the esophagus, and we've goosed the patient. We put it in the goose, the esophagus. So trachea. Below the trachea is what? You go down the trachea, it splits into two sides. What are those structures called? Exactly, Samantha. Time to refresh. Yes, the bronchus, the bronchi, the primary bronchi. Yes. This is your main bronchi. And we have right and left main bronchi. I love it. Then, below the bronchi, what do we have? What is next after the bronchi? And we're going to lump, I know there's a bunch of structures here. We're going to lump them together, and we're going to call them the, let's see if someone will get it before I say it. Bronchioles. Yes! I'm working with a smart group here. So Bradford, hold your thought for 1 second. Hold your thought. We're going to come back to that. These are the bronchioles. These smaller airways outside of the main bronchus. Then, after the bronchioles, Bradford, this is your time. What is next? What is next, Bradford? Bring it. What is after the bronchioles? The alveoli. And then he spells it wrong. Bradford, that was your shot, man. You spelled it wrong. Come on, Bradford. I opened this up to you. Okay, alveoli. That is correct. The alveoli. Now, you lay out all this anatomy. And when you have all this anatomy, what's easy to do is to get lost in the minutia of the anatomy. And what I would encourage you guys to do with your coursework, right, we want to get out of the minutia and get into the function. So I only care about the anatomy so much as I care about the function. And really, right, I've pointed out a couple ways in which the anatomy matters for the function. The oropharynx moisturizes, so if you bypass that, you worry about moisture loss. The trachea is the conduit to the right and left main bronchi. So you have to make sure, right, if you're doing something just to one of these and not to both, you can mess around and univent. So now you're only ventilating one lung, right, or you're ventilating the left lung. Additionally, these each sides have two different characteristics. Your right lung has 3 lobes, your left lung only has 2 lobes and a lingula, because it doesn't have room and has the heart on that side. So it only has 2, so there's big differences in those kind of things. These all kind of blur together, and then you have the alveoli. In this airway, each of these anatomic areas has a function. And if you can link the anatomy to the function, it'll make it easier for you to remember forever, Samantha, who needs to review on her anatomy and physiology. The upper airway is what? So we divide the airway into 2 main sections, and this is what really the anatomy matters for. What are the 2 main sections of your airway? We have the upper airway, which is a certain type of airway, and we have the lower part of the airway, which is another type of airway. Give me what you got. Give me what you got. Who's got it at Ross? Who's got it? Upper and lower. It's not upper and lower. Tori, don't feel left out. I'm bringing you anatomy and physio right now. Don't worry. At the end of this, you're going to feel like you've taken lung anatomy and physiology. So yes, Jason, it's upper and lower, but what's the distinction? So why does it matter if there's an upper airway and a lower airway? What does it matter in terms of function? Why does it matter that we have upper airway and lower airway? If you just memorize upper and lower, it's hard to do that because you don't understand why it matters. And if you understand why it matters, then it all comes together. Who is this? Keybert is on it. On it. Close. Lower airway is for gas exchange. And I'll give that to you guys. That's fine. You guys are bad. So the bronchioles, and particularly the alveoli, are the lower airway. And then everything else is upper airway. And the importance of this is that this is what's called conducting airway. And this part is called respiratory airway. And the significance of this is, just like Calvin just mentioned, is dead space. The upper airway, or the conducting airway, is a conduit. It conducts, moves air to get it to the place where it can respiratory rise, right? That's a word. Where it can gas exchange and go through respiration and take oxygen in and ventilation out. So it means that this part of the airway actually does the gas exchange, the lower part. The upper airway does nothing but be a tunnel and a conduit for gas to move. And that's significant when we talk about delivering air or breathing, because when you take shallow breaths, right, you hypoventilate, you underventilate, and you're taking shallow breaths, you move air only this far, you aren't actually doing gas exchange. Boop, 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 boop. You're not getting any gas because only this part of the lungs do gas exchange. That's why it matters. So now, right, we're tying concepts together. You can memorize all this small stuff, but really what's important before you memorize all these small things is to memorize respiratory and conducting. Because that's what's on your test. Okay, look at the picture. Is it upper? Okay, if it's upper, that means it doesn't do gas exchange. If it's lower, it does gas exchange. And you can use just that to get a lot of the questions right on your test. And it gets into all these other things we're going to get into in a second. But does that make sense to everybody? Everybody get that? Everybody get that? Everybody get that? Everybody got that? So where's my eraser at? Have you guys seen my eraser? Oh, here it is. Okay. All right. Also, while I'm going to erase this for a second, do keep in mind, guys, we're doing Facebook every Monday, Med School Motivation Monday. It's off the hook, so get on my Facebook page if you aren't already over there. So, everyone got this emblazoned in their mind? The other thing I wrote here is pulmonary vessels. So blood carries CO2 and oxygen, the vessels. So it's important that we get circulation of blood, otherwise we can't do gas exchange because there is no, and everyone remembers this, diffusion. You remember diffusion? Oh man, diffusion doesn't matter. All my basic science classes, none of it's relevant. None of it's relevant. It is. These airways do not have semi-permeable membranes. Do you remember that term? They don't have these, therefore they don't allow air to cross. These are semi-permeable. Therefore, if a gas molecule is here or a gas molecule is here, they can exchange across a gradient. Remember that? And exchange gas. So you have to have blood circulation and you have to have the gas molecules coming down to be able to do that, to establish a gradient to be able to go across. This is important because someone mentioned dead space. There are two terms that you have to memorize. So we've got function and anatomy down. So now we're going to move to physio/pathophys. So when things are going right, we have an alveoli and we have a vessel going by it. That vessel carries CO2 across. This alveoli introduces oxygen and they exchange. As blood flows by, CO2 is coming out, oxygen's going in. It's all great. But there are two scenarios when this gets messed up and you get pathophysiology. The first is when you don't get blood circulation. So the case, when might blood circulation be cut off to your lungs? Give me the one big example. There's a million, but give me the one big example of when blood stops flowing to certain parts of your lungs. Frank must have like autotype on, man. This cat is fast. PE, the pulmonary embolism. So if we have blood flowing through to our alveoli, and then all of a sudden we get a fat clot. Right? Pulmonary embolism, it stops the blood from flowing. So now we have an area that gets oxygenated, but doesn't get blood flow. That's a pathophysiologic state, and what is it called, guys? What is it called? I know Lexi's like, go Frank. Frank's balling out. So Bradford, cardiac tamponade does not affect pulmonary blood flow. It can eventually, but it is not a direct cause of what we're going to talk about in a second. What is it called? What's it called, guys? Sorry guys, I just got a message here. Hold on 1 second. I'll be back. Okay. What's it called? When you get a clot and now you don't get circulation to a part of the lung that is getting oxygen. No. Frank, you are wrong. It is not infarct. Somebody type it. Let's go. Bring it. Let's go, experts. Bring it. Oh, you guys are weak. You guys are supposed to be experts. Weak. When blood stops flowing to a portion of the lung that is still being oxygenated, That's called dead space. We're getting oxygen, but we can't do gas exchange because we have no blood flow. It's called dead space. This is important because remember we said that we have the two types of airway, right? We have the conducting airway and the respiratory airway. Well, since this is a condition where there's no blood flow, but there is oxygen, we have physiologic dead space. Not patho. This is pathophysiologic dead space when you get a PE, but normal physiologic dead space occurs in the conducting airways because you're moving oxygen, but there is no gas exchange because there is no blood flow. There is no permeable membrane to actually do gas exchange. So dead space. Everybody got that? Dead space means oxygenation, so there's gas present, the lungs are working good, but there's no blood flow. Dead space. And the way I remember that, so I'll teach you the other term first, I'll tell you how I remember that in a simple way. But the other type of situation you can have is you can have a situation where you have the vessel, right, and you have the lung, and the lung can be diseased. The lung is broken, but we're still getting blood flow. So what happens, what is it called when we don't have the lung working, but we still have blood flow to that lung? What you got? What do you got? That's dead space. What's the other big term you heard in physiology class? Who said that? Kiglia said live space. I like that. Live space. Kieber, got it. Shunt. This is shunt pathophysiology. So now we are shunting oxygen away from where blood is. And the way I remember these two, because it can be confusing, okay, which one is the one with blood, which one is the one with oxygen, is that I think when you're dead, you don't have blood flow. Dead person has no blood flow, so I think dead space is no blood flow. I think shunt is like when you shunt or punt, right, the oxygen away from the blood. That's the way I think about it. Dead space and shunt. Dead space, I'm dead, I have no blood flow. Shunt, I'm shunting/punting away the oxygen from my blood. That's how I remember it. I don't know how you want to remember it. So we have these two conditions. Everybody good on that? These are the two major things you can have go wrong with your lungs. And there's a lot of things that can cause these, dead space and shunt and all kind of things, but the big premise is that either we stop blood flow or we stop oxygenation. One of the biggest causes of shunt is what? So give me two causes. You guys should be able to come up with two causes of shunt. You college students, what are two causes where you don't get oxygen effectively into the lungs, but you get good blood flow? So I'm going to ignore pneumothorax because that's a complex concept, Frank, and it has shunt and dead space physiology, so we're not going to do that one. But Julian's got it, Jalissa's got it, Kellermeister's got it, Kevin's got it, air obstruction. I guess that's fair. Okay, air obstruction, OSA. I guess that's kind of there. Well, kind of. But but COPD, and emphysema is the type of COPD, and alveoli filled with fluid are examples of when oxygen can't get in there. Because if you imagine, in COPD, we have inflammation and we have breakdown of the lung airways, including the alveoli. And so you lose the integrity of these, and so they collapse down. And when they collapse down, they can't get oxygen in, and so you don't get oxygen, but you get blood flow. So that's one way that you can get shunt. The other way that someone just mentioned is if you just fill this all up with fluid, there's no room for oxygen, and therefore you again can't get oxygen. Very simple. Okay. All right. Are we good there? Are we ready? Are we ready? Are we ready? Are we ready? We talked about gas exchange is two different things. It's oxygenation, which is oxygen in, and it's ventilation, which is CO2 out. This is extremely important because they're two entirely different and distinct things that are affected by different factors. Oxygenation is getting oxygen into the body. So many of you have never heard about this really before, right? Broken out this way, but it's okay. We're going to reason it out. We're going to use our critical thinking skills in reasoning. We just said, right, the lungs' job is to bring oxygen in. So what are some ways that we can improve the amount of oxygen that gets into our lungs? Don't have to use complex terms. Use basic terms. Use kindergarten type terms. What are the ways that we can improve the amount of oxygen that gets into our lungs? Use basic terms, because you're going to try to use science terms and you're going to mess it up. No. See what I'm saying? So you guys are messing this up already. Don't use advanced terms. Basic. And this is where you guys mess up on tests. You try to be too fancy, too fast. Too fancy, too fast. Get it very simple. How do we get oxygen in? I'm saying BiPAP. I'm saying ventilation. I'm saying exercise. Breathe better. No. Inhaling, wrong. Cough, deep breathing. Relax, nope. Take nice long breaths. Yoga. No, guys. No. So you are just as bad as that surgery resident. But it's okay, because you guys aren't doctors yet. So you guys don't have to know this. If we want to get more oxygen in, then we can do one of two things. The first thing we can do is we can concentrate the amount of oxygen, and someone just said it. Ryan just said concentrated oxygen. We can put more oxygen in the gas we're breathing. So when someone is having difficulty with oxygenating, what do we see them do? The football players, what happens? They grab the oxygen and put it on their face, right? When they want to recover, athletes after the game, because they feel like, oh man, I've exhausted all my oxygen, I'm in anaerobic metabolism, I'm building up this lactic acid, I'm building up all this CO2, and I want to improve my oxygenation. What do? They get in a hyperbaric chamber, which increases the concentration of oxygen. Now, I'm going to take you way, way back to chemistry, which everybody on this feed better be able to give me this equation right now, or I'm shutting it down. What is the ideal gas law? What does it say about pressures of a gas and the concentrations of those gases in the situation? So if you have a mixed solution of gases, what is the relationship between pressure of a gas and concentration of that gas? So Jason is the first one to say it. They're proportional. So the higher the pressure of a gas, the higher the proportion of that gas in the solution. So if you increase pressure, you increase concentration. So there's two ways now. A hyperbaric chamber works by increasing the pressure in the atmosphere. Our oxygen tanks and all these types of things work by increasing the proportion and the concentration of oxygen directly. So the two ways we can increase oxygen is we can increase the FiO2, which is the fraction, right, the proportion of our air that we breathe is oxygen. We can increase that. In room air, it's only 21% oxygen. So only 1/5 of everything you breathe in is actually oxygen. With nasal cannula or a face mask with a tube, I can take you all the way up to 100%, so you're getting 5 times the amount of oxygen per amount of breath. The other thing you can do is you can increase pressure. And we see this, who's ever been to high altitude? And you go to high altitude and what do you feel? Short of breath. I can't, what's going on? Well, when you go to high altitude, you're above sea level, you're going way, way up, so the pressure outside has decreased. And as the pressure has decreased, it decreases, right, the amount of oxygen that's going to be delivered into your lungs. We can do that artificially, medically, and I do it all the time, and it's in the form of PEEP. Positive end expiratory pressure. You may have also heard of CPAP. But you do these types of things to increase oxygenation. So if I have a patient who is failing to oxygenate effectively, their pulse ox all of a sudden was 100%, then it's 95%, then it's 85%, then it's 80%, then it's 60%. I'm like, oh my gosh, what's happening? What do? I don't freak out. I go right back to my basic physiology. And I remember my physics and my chemistry. Fraction of inhaled oxygen, ideal gas law. I remember PEEP or CPAP. So I increase the PEEP. I put them on CPAP. And so this will happen. So for my people who have OSA, right, my obstructive sleep apnea people, you have issues with oxygenation because you occlude the airway and so oxygen can't go in. So how do we improve your oxygenation? We give you a mask that pushes pressure into your face in the form of continuous positive airway pressure, CPAP, that opens up the lungs and allows you to get more oxygenation, right? It saves your heart, it saves all the kind of things. It's amazing. That's what CPAP does. Everybody good on that? Are we good on that? All right. Now, I'm going to get really complex here. Is everybody ready for this? Bronchial alveoli. The alveoli is a circle. It's rounder than what I just drew there. It's a circle. It's tissue. It's kind of floppy, kind of stiff. And so what it can do is it can collapse on itself. If you think back to your physics class, you learned Laplace's law or whatever it might be. I forget exactly how to say it. I have horrible pronunciation. But essentially, what did you learn about a sphere and how to keep a sphere open? You learned this equation. Who remembers that? In order to get oxygen in, you need this alveoli to be open. When this alveoli closes, it's called atelectasis. Closure of the alveoli is atelectasis. This equation represents the pressure. Everybody with me? This equation represents the amount of pressure that is affecting this alveoli. Okay, I want to make sure I don't lose people here. So if we're all caught up to where we are now, ignore this. If you understand the concept of atelectasis in this closing, let's start there. Do you understand that? Okay, everybody's there. So now, in physics, an orb has what's called a closing pressure. And so every orb that's under pressure from the outside and from the inside, right? So the pressure is to close this. And that's this. So, sorry, it's to close this. This pressure is the pressure required to keep the alveoli, to resist that closure. So the alveoli want to snap shut via this pressure. This pressure over here is the pressure required to keep it open. This pressure to keep the alveoli open is governed by this equation, which is a simple physics equation. 2 times the surface tension of the sphere divided by the radius. In physiology class, you may remember that you learned about 2 types of lung cells, type 1 and type 2. One of those types of lung cells, right, created a material called surfactant. Everybody remembers that? Surfactant. Surfactant's job is to reduce tension, the surface tension of this bubble. And by reducing surface tension, we decrease the numerator, therefore we decrease, right, the ultimate thing. So if we can create a bunch of surfactant, lower our surface tension, we can lower the pressure required to keep these lungs open. And this is what happens in premature babies, the biggest problem why premature, if you're like 20, why the reason they say like 24 weeks is a viable period, is because before 24 weeks, your lungs aren't even near close to fully developed. And one of the biggest problems your lungs have in not being fully developed is they don't have enough surfactant. And so when you don't have enough surfactant as a premature baby, your alveoli are at great risk to close and become atelectatic, something like that. They're at risk to go into atelectasis. Yes, it is a group of emulsifiers. That's correct, right? But atelectasis. So when you're a baby, you don't have surfactant, your lung airways are going to close because they're going to become atelectatic. And if you imagine you're a baby and all your lungs close up, what can't you get? Have you created shunt or dead space? If all your alveoli close, this is a review right here. If you're a baby, you have no surfactant, and all your alveoli close, what happens? Shunt or dead space? Shunt, yes! Kevin, don't say dead space. Come on, it's shunt. It's shunt. Because now we've punted the oxygen away, and so we have blood flow, but we can't get oxygen in. And if you can't get oxygen in, you don't have any fuel, right? You can't go through your electron transport chain. You can't do energy. You can't do, with no energy, you can't do work. Without work, your tissues don't work, your cells don't work, your organs don't work. You go into organ failure and you do what? Die. 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 Does that make sense to everybody? So premature babies are at risk for death greatly because they shunt oxygen away. Surfactant handles this. The other thing that will reduce the amount of pressure required to keep these open is to increase the radius of the alveoli. We increase the radius of the alveoli by opening them up. And how do we open them up? By applying pressure. So we artificially, with PEEP, we increase this number here and we increase that number there. Sorry, we decrease this number here, increase this number here. Does that make sense? Someone said they don't understand, so I'm going to repeat. So a lot of people are saying it makes sense, but someone doesn't. I'm not going to leave anybody behind. This is no man left behind. Our alveoli want to collapse. We have a constant pressure pushing them closed. So the pressure required to keep them open is represented by the equation 2 times the surface tension over the radius. To understand this, you have to understand fractions first. The way what we want to do is we want to reduce the amount of pressure it takes to keep our alveoli open because we want our lungs open all the time. We always want to breathe. To do that, our body produces surfactant, which reduces the tension, which therefore reduces the pressure required to keep them open. Additionally, we can apply positive inexpiratory pressure or continuous positive airway pressure to push and splint. It's like someone standing against the wall and pushing the alveoli open. By pushing the alveoli open, we make the radius of the circle bigger, and by making the radius bigger, we make the pressure required to keep the alveoli open smaller, because radius is in the denominator, and the denominator, as it gets bigger, makes the overall number smaller. So this is why it's so important to understand basic fractions. This is why so many of you guys get smoked in chemistry and in biochemistry and OChem, because you don't understand basic fractional relationships. Therefore, how can you attack osmolarity, osmolarity? How can you attack balancing equations? How can you attack all the different physics equations, you can't attack equations because equations are simply proportions represented by non-numeric factors. So if you suck at fractions, you will suck at a lot of different things, which is what happens to people in geometry. Like, oh yeah, I was great at algebra and I suck at geometry. No, you suck at algebra. You don't know fractions, therefore, when they put a fraction on a triangle, you can't do the math. That's your problem. Anyway, everyone good with that? With oxygenation. So oxygen in, gotta get it in. If we want to improve our oxygenation, we improve our FiO2 and we improve our CO2, or we improve our PEEP. Ventilation, on the other hand, is getting CO2 out. To get CO2 out, there's two things we can do. How do we improve our ventilation? No, not positive thoracic pressure. Jason got it right. He said increase the respiratory rate. So ventilation, how we measure it, is minute ventilation. So our ventilation per minute. Our minute ventilation is determined by our respiratory rate, so how fast we breathe, and then how much we breathe, tidal volume. So the amount of air I move with every breath, multiplied by the times I breathe every minute, gives me a minute ventilation. And that minute ventilation, right, per minute is how much we're ventilating and how much CO2 we can get off. So as an anesthesiologist, it's my job to set the appropriate ventilation for patients, because when I put you to sleep and I give you narcotics and I give you all these heavy drugs, I turn off your brain and I turn off your drive to breathe effectively and to ventilate and to oxygenate. So it's my responsibility to give you enough oxygen and support and enough ventilation so that you can get in oxygen and get out CO2. So I am constantly looking at the patient's minute ventilation. The only problem is, right, this is a calculation. And so if you only look at the patient's minute ventilation, and a normal minute ventilation is anywhere from like 4 up to like 7. And it's liters per minute. That's normal. But if you just look at the number, and this is where a lot of you guys run into problems on your test, is you'll write down an equation and then you only really understand this part. So, oh, okay, yeah, normal is this, blah, blah, blah. But you don't go into the details of this. So, I can look at this and be fooled because it's respiratory rate and tidal volume. So yes, I can achieve a nice minute ventilation, but what if my tidal volumes, and a normal tidal volume is anywhere, it's 6 to 8, so we're gonna get complicated. So this is where your math skills and where all that stuff you learn comes into play. So every year, you guys always say to me, none of the stuff I learn is relevant. All of it's relevant. This is simply, right, an equation like you would do in any of your classes. So working with equations is hugely important. And every day, I have to calculate tidal volume that's appropriate for the patient, and it's weight-based. So the average human being weighs 70 kilograms. We do everything in kilos. 70 kilograms. A normal tidal volume, an acceptable tidal volume, is 6 to 8 milliliters per kilogram. So if the average person is 70 kilos, a average normal tidal volume is anywhere from 420 cc's or mLs, all the way, and that's 6 times 70, right? That makes sense. All the way up to 8 times 70, which is 560 cc's. Does that make sense to everybody? So a normal person, I need to make sure that I'm giving them this tidal volume. I'm going to get to this in a second and explain to you why this is important. Respiratory rate, what's a normal respiratory rate? What do you breathe in a normal minute? Do you breathe 60 breaths a minute? Or do you breathe 2 breaths a minute? Right? 12 to 20, 20 is a little high. It's like 12 to 16. You can even drop it down, 8 to 16. When you're relaxed, about 8 to 16, you can go up even higher, but it's 8 to 16. So this number times this number gives you a minute ventilation. And why this is important, and the intricacies of this are important, is because and this is why I thought our discussion would be good today, because I'm going to talk about compliance. This is really what I think is fun, is our lungs have a certain compliance. If you imagine, our lungs are like big floppy balloons. They're big balloons, right? You blow them up, you bring them down. What does P stand for on that graph? Pressure, exactly. What does V stand for? Volume. This is a pressure volume loop. And this is why this is important. And you guys learn this in physics, and you learn about pressures and volumes. And you're like, what does this have to do with anything? It's hugely important. Pressure volume loop in the lung. I'm going to skip a lot of the rigmarole on how this is calculated. I'm just going to show you this. Okay? This is the curve of your lung compliance. If we're imagining big balloons, right, that we can expand out, compliance is how stretchy the balloon is. Compliance is the equation delta V over delta P. A change in volume over a change in pressure. What that means is the more compliant a lung, right, the more stretchy a lung is. So think about like Lululemon stretchy pants. They got those 3 different models, right? They got the one that like holds you all the way in. They got the one that just lets your booty hang out, right? They got all these different styles for whatever your body type is and however you feel like rocking it, right? And then if you go and you get the cheap spandex, then right, they come all see-through because they're super compliant and they stretch open. Everybody can see all your underwear, right? That's real. That's life. So that's compliance. So if you got a lot of booty, right? You got lots of volume going on. You got this is bad. Let's go back. Let's get science. Compliance, okay? If your lungs are very compliant or stretchy, what it means is that you can put a lot of volume, you can easily blow the balloon up with very little pressure. Very little pressure. Right? I can get lots of volume change with a little bit of pressure. On the other hand, if my lungs are very stiff, in order to get lots of volume in, I require lots of pressure because the walls are stiff. Get off of me. Push, right? Lots of pressure. So compliance is stretchiness, and stretchiness is determined by the change in volume, the change in pressure. We're all good there. This curve represents normal compliance. And what it says is, it takes at low lung volumes, at very, very low lung volumes, the lungs are not very compliant. And at very high lung volumes, the lungs are not very compliant. So why does that make sense? I just told you guys about atelectasis. When our alveoli are starting to collapse and their radius are getting smaller, it takes more and more pressure to get them to open up because they're very now, right? They want to collapse. They want to collapse. They want to collapse. So this is your atelectasis area. So when your lungs are closing down, your alveoli are closing, as they're closing, it takes more and more pressure to really open them up and snap, pop them open. It takes lots of pressure. So you get atelectasis, it's bad because your lungs are not compliant, so it's going to be hard to effectively ventilate the patient and deliver good volumes without having to give lots and lots of pressure. On the other end, now we've opened up the alveoli, we're getting good, right? A little bit of pressure change, lots of volume change. Great, we're getting lots of volumes. And then when we start getting to really, really high volumes, we need lots more pressure to get volume in. And that makes sense because now we've expanded the lungs out as far as they can go, right? That balloon is like, oh, it's super tight, it doesn't want to go any further. And so now it's trying to resist you and snap back. This is a zone of hyperinflation. Lungs don't like lots of pressure because you can cause what's called barotrauma, right? And baro is like a barometer, it's pressure. So when you deliver lots of pressure to the lungs, you risk essentially blowing a flat tire in your lungs and just blowing it out. Trauma. So you want to make sure that you're in this area of ventilation. To do that, that's how we determine 6 mLs per kilogram, 8 milliliters per kilogram. So the reason we want to ventilate from 6 to 8 is because that's supposedly in this area. And when you get higher, you're going to get poor compliance, you're going to be hyperventilated, you're going to risk blowing out the lungs. When you're down here in the low area, you're going to risk getting uneven shunting where parts of the lungs are closed and parts of the lungs are open. So if you imagine, again, taking you back to your basic classes, what determines flow? What's the equation for flow? What's the equation for flow? So what determines flow, guys? My physics, my physiology people. Delta P, who remembers that? Stuff will flow from a gradient. The higher pressure to the lower pressure. Which is why, right, when I push on this side of something and there's nothing else pushing on that side, my push is higher pressure, will force that object into lower pressure. That's why your blood pressure works. Your heart generates a super high pressure to push the blood to the low pressurized circuit of all your capillaries. So it's high pressure to low pressure, that's why blood flows that way. So it's change in pressure. Does everybody understand that? stuff will flow, right? Will go to the area of lowest resistance. The high pressure pushes it to low pressure. With that being said, if I have two areas of lung, and one area of lung is a small radius, and one area is a big radius. I taught you guys the equation for these wanting to close. Which one of these, we'll say A or B, you guys can vote. This one has a small radius, this one has a big radius, so two alveoli. Which one of these wants to close harder? So which one has more tendency to close? So there's more inward pressure. Which one of these? A or B? A lot of mixed results here. The answer is A. Remember? The smaller the radius of the alveoli, the more the alveoli wants to snap closed, which is why it's important to splint it open with PEEP. And so this one wants to close. So it has lots of pressure bringing it inward. Therefore, if I'm bringing in oxygen from up above to two areas of the lungs, and I'm applying a certain amount, let me erase this and make it clearer up here. And you don't even have to memorize this, guys, because again, right, we're trying to create frameworks. This makes it super easy. Just visually, if I was going to tell you, hey, put something in this red one, put something in this green one, which one do you think it would be easier to put like jelly beans in? The red or the green? Which one could I fit more jelly beans in? The red or the green? The bigger one, of course, right? It's bigger, so it's easy. Just drop the jelly beans in there, we're all good. As opposed to a small little tiny hole. It's the same way with gas. So you can memorize all the stuff I just told you. I don't. I just say, okay, if it's smaller, that means it's smaller, so it's at a higher pressure, right? Remember our gas stuff, a smaller container will, right? A change in volume, smaller volume, more pressure. So if I have a small area compared to I have a big area, I'm gonna have more pressure here. So I have more pressure here, and I'm as a ventilator, right? So as an anesthesiologist, I deliver a big pressure up here. And here, I have this much pressure, and here, I have this much pressure. So I have lots of pressure. This pressure is higher than this pressure. Where will the gas that I deliver, where will it go? To the red or the green? And we said that flow is the delta P, so the change in pressure. So lots of pressure, medium pressure, a little bit of pressure. Will the air go to the green or to the red? Okay, we're learning now because everybody's getting the right answer. I'm liking it. I'm liking it. Green. It goes to the green. That's absolutely correct. It goes to the green. Now, this is where it brings it back to my patient, right? It brings it back to my patient. We want to make sure that we're in this zone and we're not hyperventilating and creating lots of pressure to cause barotrauma and breaking the lungs open. And breaking the lung. Theodore, what is up? Okay? We don't want to break the lung open. So in my patient who got a lung transplant, right, she has a fresh new lung. She had a COPD in her old lung. So what does COPD do? Right? What do we say that COPD does? It breaks the integrity of the alveoli. So her COPD lung, this side's all broken, so it collapses. So this is her COPD lung. This is her good lung. So when we deliver lots of pressure to try to get air in, it's disproportionately going to go to the good lung, and we're going to damage that brand new lung she's got transplanted. And it's going to be awful. And we're going to destroy her lung. So what we have to do is get her optimized for her compliance. And so we literally will do all these different thought processes and calculations and sit down as a team and be like, okay, wait, where do we think she is on the curve? Okay, well, how many mLs per kilogram are we delivering? What is the peak pressure we're achieving when we deliver it? How much pressure do we need to give to get a volume? Oh, well, that's a lot of pressure for a little bit of volume. So that can't be, her compliance is bad. She's either up here or she's down here. Okay, well, based on our right? And you can go through all these different equations, and we use a bunch of other things, but this is to simplify it for you guys. And we can change, we have like 15 different vent settings we can do, and we flip through the vent settings, do different things, and change different parameters to get her optimized. The other thing we can do, right, is I'm going to take you back to physics again, gravity. Gravity pulls things down. So if we have a lung that is more collapsed than the other lung, we'll turn the patient on their side with the lung that is really smushed down on top, because then gravity will pull it down and pull it open and splint it open and help us deliver pressure. So that's why you see sometimes, and you guys can look this up, but there's beds that will actually, they're like the Bruce Lee beds. They strap around the whole patient, and we can actually turn the patient 360 degrees, and we can actually turn them so that way we can drop a lung and have it actually open up and get effective ventilation and oxygenation to that lung. And so what will happen during surgery, I'll turn patients, I'll do different things, and we have tubes where we can move the tube into one lung and make sure we're giving only one lung, or we can do different pressures of different lungs and all kind of stuff. But all day I do physics, I do chemistry, I do all these advanced concepts thinking about how I'm keeping the patient alive. That's what it's all about. And next week, since some of you guys, who likes this physiology stuff? All right, I'm seeing lots of loves it and liking it and amazing it. Okay, so that's what the whole, this is stuff I do every day. And if you imagine, right, all this stuff, and I could go, we do this with every organ system. So it's a lot of stuff to memorize. And that's why it's important, right, so that you have to, right now, you have to start putting in frameworks that make it easy for you to remember stuff. It's hard to remember that radius equation. But if you could just draw it out and think about it and be like, wait, if I'm putting marbles or anything into this is going to be easier. It's bigger. This is smaller. Oh, dang, right? And it makes it happen so you can memorize things. And you can put all these things together, pressure volume loops, you learn it now, all this stuff. It makes your life so much easier. And the reason I chose anesthesia is because, A, you know baller stuff. And so I know the difference between oxygenation and ventilation. You know this now too. But so you'll see someone in a COPD patient, and COPD patients, their lungs collapse, right, because they have loss of infrastructure, so therefore they can't effectively ventilate, they can't get CO2 out, so they accumulate CO2, and so their CO2 levels are super high. So normal CO2 is like 40, they're in like the 60s, 70s, I've even seen like as high as 80. Now if you had a CO2 of 70 or 80, you'd probably pass out. Hypercapnia, yes, Frank, right, but you have these CO2s. So in COPD patients, they have really high CO2 levels. So what you'll see people who don't understand oxygenation versus ventilation do is they're like, oh, their CO2 is high. Let's turn up their FiO2 and give them lots of 100% oxygen. And what happened was, and this actually came out, a lot of people with COPD were dying at home, and the reason they were dying at home is because they were on oxygen tanks. Well, if I'm a COPDer, my issue is not oxygen, my issue is ventilation. So now I'm sitting here thinking I'm getting good air, right? And I'm getting all this oxygen, and we won't even get into this topic, but right, we talked about, someone said central apnea. But our body has sensors to keep us in homeostasis that detect levels of oxygen and CO2. And in chronic CO2 retainers like COPD people, your body resets and says, listen, my CO2 is chronically elevated, it's just gonna be high, let's just call this normal. Let's call 60 normal. And so it doesn't drive to breathe off that CO2 because it's like, man, this is the best I can do. Therefore, if you give them a bunch of oxygen, you're gonna activate the oxygen sensors that are saying, wait, we're getting tons of oxygen, we're breathing too much. And so what happens is their respiratory drive actually goes down, they stop breathing, they suffocate with 100% oxygen. They go hypercapnic and they die because they were getting too much oxygen and telling their brain the wrong thing. And what I actually will relate this to is, I'm your CO2 receptors. I'm trying to tell you, breathe, y'all, breathe. And all the rest of these fakers out here and your pre-med advisors are these oxygen, 100% oxygen that are sabotaging you and telling you not to breathe, and then you die. And they're killing your medical school dreams. It's a good analogy, right? So that's why all this stuff matters. And so I love my job because, A, I know functional stuff. So when someone's doing oxygen treatment for someone with COPD, I'm like, you're an idiot. Let me turn the vent settings and change our ventilation, and I can be a baller and save a life while they can't. It's cool. And now you guys know this stuff, so now you guys can go save a life. But that's what it's about. And so I love anesthesia because I get to do calculations and crazy stuff like this all day, every day. It's all we do. And I would tell you guys, but we don't have time. We're about an hour and 10 minutes. But we have heart failure patients, like I said, we do heart physio for hours. I love it, right? And all the different devices they can do, and it's so much fun. But anyway, the whole objective of this is to teach you guys some respiratory physiology. And this is kind of on the advanced side. There's some basic stuff that you should learn for your physiology class, right? But this is advanced stuff. This is way more detailed than any of your college physiology classes are going to go into. And so my point is if I can easily teach you this in an hour, imagine if you had skills to frame things and conceptualize things yourself, how easy a basic rudimentary physiology class becomes. And so I encourage you guys to develop these kind of study skills, however you might want to do it. But if you really want to do it, get in one of my classes, like my 5 Pillars course, where we talk about creating frameworks and working through materials and different kind of things. But this is what you guys want to do. And people keep saying I should do a lecture series. The reason I don't teach specific topics, yes, I can teach physio and chemistry and bio all day, right, in my sleep. The reason I don't teach subject-specific stuff is because I liken it to the analogy of you can teach a man to fish, you can give a man a fish and he'll eat for a day, or you can teach a man how to fish and he eats for a lifetime. I have no interest in giving you guys fish. I am only interested in turning you into master, like, what is that show with the people on the boats called when they go out and they get the crab and the fish? What is it called? Deadliest Catch. My mission is to turn you guys into some deadliest catch fishermen, where you are going out and you are catching all the fish in the world because you know how to fish. That's what I'm interested in doing. So my learning class teaches you how to do this for yourself. That's what it's about. So recognize, guys, like I don't care about giving you fish. I want you to be able to fend for yourself. So when I give you advice about how to get to medical school, I'm giving you tools for you to assess your own journey and your own path and not have to follow strict rules, because it is very variable all over the place. So that's what it's about. Recognize. It's an hour and 10 minutes of respiratory physiology. And we didn't even I had like so much more stuff to talk about on this thing, but we're getting kind of long. And I think you guys are getting the point I'm talking about. People got like work to do. School is starting back. And I don't want to hold you guys back from that. But I hope you guys enjoyed this lecture tonight. This was totally different than what we normally do. But I thought it was a good topic. And since Jet just asked a question, this is Premed Q&A, I'll answer this one question. And we'll do one more question. So give me 2 questions and then we'll get out of here. But the first one that just got asked by Jet was, how hard is med school? Well, like any other question, right? So Jet, if I asked you, how hard is riding a bike? What would your answer be? How hard is riding a bike, guys? So Jet and Junior fell into a common trap, which said easy and not hard, and McDonald's ketchup said easy, right? Easy, 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 not hard. But what you fell into the trap of is the fact that you've been riding a bike since you were a kid, so of course it's easy to you now. What you've forgotten about is when you were 5 and you had never ridden a bike, how difficult it was for you to do because you were inexperienced. And a lot of other people said very hard, right? So it depends on your ability to ride a bike, your knowledge and experience in doing those kind of things. Medical school is all about learning, right? They say the fire hose. Learning a lot of material in a short amount of time. Therefore, when you say, is medical school hard? It's all relative based on your ability to study and learn effectively. For me, medical school was not hard. And that may sound crazy to you guys, but medical school was not hard for me. It was a lot of studying, yes, but it was not hard because I had superior study skills. Now, for other people who didn't have superior study skills, it is very hard. So you have to ask yourself, right, if you're struggling in your undergrad classes that are cake, and you're going to go on to medical school and think you're going to thrive, you're sadly mistaken. If you're barely hanging on and you're studying 24/7 in undergrad to barely get that A, you're in for a rude awakening when you get to medical school, because you're going to get there and now it's going to be ramped up 10 times, but you can't create 10 times the amount of time in your week. So all you can do is fail and suffer and say, oh, it's so hard. It's like drinking from a fire hose. But cats, I'm prepared for fire hose drinking because I've been drinking from the fire hose my whole life. I'm ready to go. So it's easy. It's all relative. So when people say, oh, medical school is hard, or medical school is easy, whatever it might be, it's relative. And I say medical school can be easy and it should be easy. So get at it, right? Learn how to study, learn how to learn. It's much more valuable than learning one single topic, because then when that topic's over, you're done cakes, right? Oh, I did well in this class, but now I'm worried about, well, why are you worried? If you had some study skills, you'd be all right. But the problem is you don't got no study skills, so you're in trouble. I am the Mayweather of studying, recognized, but not this past weekend. I didn't really care for Mayweather this weekend, but I am. I'm tactical. I'm in there, right? I'm getting in, very little damage to my body, and I'm body bagging, studying. I'm body bagging course materials. Boom. Chemistry, you're knocked out. Biochem, you're knocked out. All that kind of stuff. So recognize. So anyway, these are all my cats in my class that are hanging out with me right now that are saying, get the study course, it's amazing. Because they know, guys, it's amazing. We're having fun. And again, I said this earlier today, so there's going to be some emails coming out tonight. For you guys who are emailing me, I'm returning a bunch of emails tonight. I returned about 200-something emails earlier today. I'm going to do some more emails tonight, but I'm so proud of my cats that are in my courses and in the group who are participating, and I'm very happy with it because it's off the chain. I'm very excited because it's coming together. We are a community of one, and we are uplifting each other, and I'm loving it. I'm loving it. So anyway, you guys have an awesome night. So who's this? Mernaz said, I've emailed you multiple times. Well, if I have not got back to you, email me more times. I'm trying to return as many emails as I can. I get tons and tons and tons of emails every day. I'm getting through them as fast as I can. So McDonald's Ketchup said, how do you get the study course? You get the study course by going to my website, www.premedproductivity.com. Sign up for the course right there. And it's actually important. It's very important. I'm going to make an announcement on my social media. I'm closing down my private group. You will no longer have direct access to the private group if you don't sign up this week. Friday is the last day where if you buy my premium courses, you get access to this exclusive group, because I don't like weeds in my garden of beautiful roses that are sprouting. So weeds will be cut and you will have to apply to get into this bonus group. For the rest of you guys, if you get in right now, you can get in. So I appreciate you guys. Thank you so very much. And I'm out of here. I'll see you guys on Monday on Facebook. And I'll see you next Wednesday here on YouTube, 6 p.m. Pacific Standard Time, as always. I appreciate it, guys. I appreciate you being on here. And, yeah, see you guys later.